Welcome. Today's learning resource will focus on the diagnosis of diabetic foot infections, as infections can progress quickly in diabetes patients. Clinicians must pursue and gain a diagnosis in an effective manner. In this session, we will outline the key methods used to diagnose diabetic foot infections, including clinical diagnosis based on assessment, wound swabs, and cultures, imaging investigation, and blood tests.
Clinically, infection is diagnosed based on the presence of two or more classic findings of inflammation or purulence, as outlined in the assessment video. The infection should then be classified as either mild, moderate, or severe. This diagnosis of an infection severity therefore determines the appropriate management plan required for the presenting infection. This table by the Infectious Disease Society of America, an international working group, outlines the classification for a diabetic foot infection, which will now be discussed. For a mild infection, diagnostically, it involves only skin and subcutaneous tissue, with erythema greater than 0.5 centimeters to less than or equal to 2 centimeters around the infection site. Differential diagnoses that cause an inflammatory response of the skin, such as gout, trauma, Charcot, or a fracture, must be excluded. A moderate infection diagnostically involves structures deeper than the skin and subcutaneous tissue. Erythema is present more than 2 centimeters around the infection site, however, no systemic inflammatory response signs are present. A severe infection diagnostically involves local infection as described previously, accompanied by 2 or more systemic inflammatory response signs, being a temperature greater than 38 degrees or less than 36 degrees, a heart rate above 90 beats per minute, a respiratory rate of more than 20 breaths per minute, and/or a white blood cell count greater than 12,000. Additional signs and/or symptoms of systemic infection include hypertension, confusion, vomiting, severe hypoglycemia, new onset azotemia, and/or evidence of metabolic disturbances such as acidosis, being increased acidity in the bloodstream and/or tissues. As a podiatrist, it is key to educate diabetes patients with an infection that if they begin to feel overall unwell, notice spreading erythema, and/or have a severe spike in their blood glucose levels, to attend to the emergency department immediately, as the infection has become severe, which is life-threatening and requires immediate emergency care.
For suspected infection, a post-debridement specimen should be obtained so that the causative pathogen can be identified and antibiotic therapy can be narrowly targeted. Infectious Disease Society of America recommends sending a specimen for culture days from deep tissue, obtained by biopsy or curettage after the wound has been cleansed and debrided. They also recommend avoiding swab specimens, especially of inadequately debrided wounds, as they provide less accurate results. For osteomyelitis, the Infectious Disease Society of America recommends that it should be optimally diagnosed by bone culture and histology. Imaging investigation is especially helpful when seeking evidence of underlying osteomyelitis, which is often difficult to diagnose and treat. For imaging investigation, plain X-ray is recommended for all patients presenting with a new diabetic foot infection to assess for bone abnormalities and foreign bodies. Magnetic resonance imaging, also known as MRI, is considered the best imaging modality to diagnose diabetic foot infection, as it is highly sensitive and specific. MRI is recommended when additional imaging is needed, particularly when soft tissue abscess is suspected or the diagnosis of osteomyelitis remains unclear. If MRI is unavailable or contraindicated, it is recommended that clinicians should preferably consider a radionuclide bone scan and a label white blood cell scan as the best alternative method. Referring a patient for a blood test is another method that can be used to assist in diagnosing the presence of infection. An elevated white blood cell count is highly indicative of the presence of infection, with a white blood cell count higher than 12,000, a systemic inflammatory response sign of severe infection that requires emergency care. Therefore, in order to accurately diagnose diabetes foot infections, it requires a combination of clinical diagnosis based on assessment, imaging investigation, wound swabs, and cultures and blood tests. Thus, From this accurate diagnosis, the appropriate management plan from the patient and their presenting infection can be effectively developed. Below are our references. Thank you for listening to our online video regarding diagnosis of diabetic foot infection.